Good evening to everyone and welcome to today's session. We invite our online students, Dr. Shailaja, Vikash, Rohit, Satya, and the students from Guntur, Vizag, Tirupati, Kurnool, to end a subject during preparation for MD entrance is also a big art. Similarly, when you investigate a patient in a general medicine ward for a fever of unknown origin, where to end your investigations also is a big art. If you take any endeavor of clinical diagnosis and evaluation, it is that comprehensiveness of the physician which differentiates between a good and a bad physician. You should not over investigate, at the same time you should not miss the diagnosis. So doctor, we had a long marathon, nearly about 40 topics in the last few days. Now today is our concluding session of physiology, where we will discuss 7 leftover topics: regulation of respiration, carbon dioxide transport, thyroid metabolism, the hormones in GIT, and the muscle stretch reflex, Golgi tendon organs, etc., and cell membrane. They are the last few topics which are waiting for our attention, with which we conclude the physiology today. Can you please punch? Is the voice is loud and clear enough for all our online students? Then I feel confident I am connected with you. Please let me know if you have any problem with the voice. It should not be. Right. Now, regulation of respiration. Fundamentally, we have an involuntary respiration. We don't plan, we don't think that we are breathing. But at the same time, if we are anxious, voluntarily we may hyperventilate. So there is a control coming from the cerebral cortical level. There is a control at the brainstem level. And in turn, there are peripheral and central chemoreceptors, which will be regulating our respiration, is what you need to be very clear. So what are the various afferents that act on the inspiratory center? We have oxygen, carbon dioxide and H+ ion concentration. They act on the peripheral chemoreceptors. Only H+, be very sure, not CO2 or oxygen. It has an influence on central chemoreceptors. Whenever the lung is expanding, the stretch receptors in the lung through the vagus nerve have an influence on the inspiratory center. Whenever we start exercise and get onto the treadmill, why our breathing rate will increase? Because of the muscle and joint receptors influencing the inspiratory center. In turn, the inspiratory center is controlled by 2 important centers called apneustic and pneumotaxic. Pneumotaxic center inhibits it, apneustic center stimulates it. And in turn, the inspiratory center through the phrenic nerve will be controlling the diaphragmatic activity, is all about the control of the breathing. So what is the most important question asked in the entrance exam about this? What is the function of apneustic and pneumotaxic center? And will all the substrates affect the central chemoreceptors? No sir. Only H+ ion is the one which influences the central chemoreceptor. That is the tricky point about this particular topic. So breathing is controlled by the chemoreceptors, which are influenced by oxygen, CO2, mechanoreceptors in the lung and joints, and the control centers for the breathing in medulla and pons, and the respiratory muscles, and the voluntary control is basically coming from the cerebral cortex. How does brainstem controls the breathing? The normal involuntary breathing is basically controlled by 3 groups of neurons in the brainstem. One is called medullary respiratory center. There is one apneustic and one pneumotaxic center. So this is the cortical control, this is the medullary chemoreceptor, and these are the afferents which are coming to the inspiratory center, to the medullary respiratory center. Now, where is the pneumotaxic center basically located? If you look at the cut section, you can see that in the dorsal pons we have pneumotaxic, ventral pons the apneustic center, and in the medulla we have two groups of neurons called dorsal respiratory group and ventral respiratory group in the medullary respiratory center. Ultimately, the medullary respiratory center through the phrenic nerve will be influencing the diaphragm. So where is medullary respiratory center located? You know that medulla or pons are midbrain. They have a reticular formation. In the reticular formation, there are two groups of neurons. Dorsal respiratory group is called inspiratory center. Ventral respiratory group is called expiratory center. A good number of times MCQs have been asked, which one is inspiratory, which one is expiratory? Is it dorsal or is it ventral respiratory group? Somehow you need to basically remember. So, we have a pneumotaxic center and apneustic center which is located within the pons. Then in the medulla we have a ventral respiratory group, dorsal respiratory group, which basically controls the rhythm of respiration. They generate the rhythm of respiration is what we have to understand. So the inspiratory center, is it dorsal or ventral? Inspiratory center is basically the dorsal respiratory center. It controls the basic rhythm and the frequency of inspiration, and it receives the sensory input basically from three locations. We have peripheral chemoreceptors. These receptors through the glossopharyngeal and vagus nerves will be communicating with this dorsal respiratory center. Dorsal respiratory group, which is the inspiratory center. Then the mechanoreceptors, which are the stretch receptors, through the vagus also will communicate with this inspiratory center. Inspiratory center in turn sends the impulses to the diaphragm by the phrenic nerve. Now, doctor, how are the electrical signals are passed through the phrenic nerve? For the basic rhythm of respiration with the tidal volume, entering in, going out, entering in, going out. How are the electrical impulses are discharged basically? There is a period of quiescence, which is the resting time, followed by a burst of action potential, which will increase the frequency for few seconds in the phrenic nerve, and once more it returns to quiescence. This is how it keep on alternating. Quiescence, burst, so on. Even if you look at the activity of the diaphragm while we are breathing, there is a quiescence, then the action potentials in the muscle of the diaphragm goes to peak frequency, and once more there is a quiescence. Now, this inspiration, it can be shortened. If this inspiratory center is acted upon by the pneumotaxic center in the pons. If the pneumotaxic center sends signals to the inspiratory center in the medulla, then this inspiration typically becomes shortened. There is a quiescence, burst, quiescence is there, no? So, this entire cycle becomes shortened. Then what is expiratory center? It is in the ventral respiratory group and it is responsible for expiration, which is fundamentally a passive phenomena. That's the reason expiratory centers are generally inactive during the quiet breathing. But whenever you are doing exercise, expiration also becomes an active process, and that time the expiratory center, which is the ventral group of neurons in the medulla, then become activated. Then what is apneustic center? What is meant by apneusis, doctor? That's very important. abnormal breathing pattern where there is a prolonged inspiratory gasp is called as apneustic center, and this prolonged inspiratory gasp is followed by a brief expiratory movement. So that is called as apneusis. It is in the lower pons where the apneustic center is located. It is also pontine. Both pneumotaxic apneustic are in the pons only. The stimulation of this apneustic area, it excites the inspiratory center in the medulla. What is the effect of pneumotaxic center? It will shortens the inspiratory cycle. And apneustic center hence prolongs the period of action potential in the phrenic nerve, and it prolongs the contraction of the diaphragm. That is the function of apneustic center. Once more to summarize, we have a pneumotaxic, we have an apneustic center, we have an expiratory, inspiratory center in the medulla, ultimately going to the expiratory and inspiratory muscles. In the upper pons, we have the pneumotaxic center. Pneumotaxic center turns off the inspiration. It limits the burst of action potential in the phrenic nerve. It limits the size of the tidal volume, and it regulates the respiratory rate. And can we continue to breathe normally even if pneumotaxic center had been removed? What happens if you disconnect the medulla from the pons and remove the pneumotaxic center? What will happen? The normal breathing rhythm, which is generated at which level? At the ventral and dorsal respiratory, inspiratory and expiratory neurons. It continues to function even if you disconnect it from the influence of the pneumotaxic center from the upper pons. So that is the reason it is one of the very commonly asked question. In the absence of pneumotaxic center, what happens to the pattern of breathing? Basically, the normal breathing rhythm continues even in the absence of the pneumotaxic center is what you have to basically remember. Now comes the cerebral cortex. Cerebral cortex, it will temporarily override all these automatic processes which are happening at the pontomedullary level. If you want, can you hyperventilate voluntarily? Definitely. If you see any hysterical person, he can hyperventilate with the professional finishing. So now, what are the consequences of that hyperventilation? There is a carbon dioxide washout, and that will decrease the PaCO2. A fall of the PaCO2, what will it do? It will lead to alkalosis, where it will increase the arterial pH. Now, can you keep on hyperventilating for a long period of time? No, sir. Hyperventilation is self-limiting in nature, because hyperventilation washes out the CO2. The CO2 washout will lead to unconsciousness, and in the unconsciousness you can't further hyperventilate. So that is the reason the normal breathing pattern once more will revert. Forever you can't keep on hyperventilating. Then how about breath holding and hypoventilation? Basically it is much more difficult, because hypoventilation will decrease the PaO2 and it will increase the PaCO2. These two are powerful stimulants of the peripheral chemoreceptors, and you don't want also those peripheral chemoreceptors come to the inspiratory center and they stimulate it. If you want to hold the breath, the moment you hold the breath, your PaO2 falls and PaCO2 rises, and that rise will automatically lead to stimulation of your chemical chemoreceptors peripherally, that comes and stimulates your inspiratory center. Nothing is under your control. So that is the whole problem. So what is preventing a prolonged breath holding by us? It is the natural rise of the PaCO2 and fall of PaO2 is responsible. So Where do you need to basically do the breath holding, doctor? Let us say you are doing a diving into a swimming pool. For a long period of time, you want to basically hold the breath. Before diving into the water, you hyperventilate for a period of time. Then what happened? You washed out the CO2. Then when you dive and hold the breath, for the rise of the PaCO2 to occur, it takes a little longer time. So that is the reason the swimming pool coach will tell you, nicely breathe out and then go into the water. So that for a longer period you can be able to hold the breath. So what is the limiting factor for hyperventilation? Unconsciousness caused by the CO2 washout will prevent further hyperventilation. For the hypoventilation, it is the rise of the PaCO2 which stimulates the peripheral chemoreceptors, which automatically will stop the breath holding to continue. So that is the whole problem. Then chemoreceptors. What are the types of chemoreceptors? We have central chemoreceptors located in the brainstem for the minute-to-minute control of our breathing. It is the central chemoreceptors, very important. They are central. That means in some part of the brainstem they are located. Where are they? They are on the ventral surface of the medulla. Why it is a very strategic location? You know very well that medulla is the place where you are having the 8th, 9th, 10th, all cranial nerves. Their nuclei are located. So the glossopharyngeal vagus brings all the information. They are only a short distance from the medullary inspiratory center. That is the ventral surface of the medulla is the point which is very closer to the inspiratory center, and this senses, this acts. Medullary inspiratory center acts to increase inspiration. Ventral surface of the medulla, that area which is the central chemoreceptor zone, will sense the changes. Now, the central chemoreceptor area in the medulla directly talks with the inspiratory center, which is also located in the medulla. Now, if you look at the brainstem's chemoreceptors, doctor, they are very, very sensitive to the pH of the CSF. You are from which college, doctor? Huh? Very good. You are also from Siddhartha. I am very happy to see you. So, the brainstem's chemoreceptor, please give to the doctor notes, Mohan. So the brainstem, you have the brainstem chemoreceptors. They don't react to the oxygen. If the low PaO2 is there, they don't know that there is a low PaO2. If the PaCO2 rises, they don't know that there is a rise of PaCO2. What they basically respond is only to the pH and H plus ion concentration is what you have to basically appreciate. So any fall of the pH in the CSF produces hyperventilation. Any rise of the pH, alkaloidic pH of the CSF will produce hypoventilation is what you have to fundamentally appreciate. Now doctor, what brings the changes in the pH of the CSF basically? Whenever a person is having a rise of PaCO2, suppose his breathing is not adequate, ventilation is not adequate, his PaCO2 rises. That rised PaCO2 combines with water to form carbonic acid. Basically that diffuses into the CSF. In the CSF, it combines with water to form carbonic acid, which will be broken down into H plus and HCO3 minus, and that typically lead to the development of the rise of the H plus ions in the CSF and a fall of the pH in the CSF, which then stimulates the inspiratory center. So what we need to appreciate is the central chemoreceptors are not at all sensing oxygen or PCO2 directly. They can only sense the H plus ion concentrations. So that is the reason any rise of the PaCO2 indirectly influences the central chemoreceptors. How? by the diffusion of the CO2 and conversion into carbonic acid and release of H plus ion and fall of pH, leading to the stimulation of the inspiratory center and the sensing of the chemoreceptor zone is all the story which is frequently asked in the exam. Examiner will be luring you in the tomorrow's AIIMS exam. Is it only H plus? Is it also oxygen and CO2? All of the above. For the central chemoreceptors, only H plus, sir. For the peripheral chemoreceptors, all the three, sir. That's what you need to be very, very sure about. Whereas peripheral chemoreceptors, both oxygen, carbon dioxide, H plus, everything is being sensed. Which part, which place are these peripheral chemoreceptors located? Typically in the carotid bodies. At the bifurcation of the common carotid artery they are located. And in turn, the information about the fall of PO2, rise of PCO2, fall of pH is being relayed from these peripheral chemoreceptors to the medullary inspiratory center. And who is communicating that afferents? It is the crenular 9 and 10. Vagus and glossopharyngeal are carrying. And any change in the arterial blood composition in turn will lead to the change in the breathing rate. So let us look at each of these changes. Fall of the PO2. Now comes a very important question. Rise of PCO2 can stimulate inspiratory center. Fall of PO2 can also stimulate. Between the two, which is much more a sensitive stimulant for the inspiration? It is the rise of the PaCO2 than the fall of the PO2. Relatively, the chemoreceptors are insensitive to the changes in the PO2. They basically respond to the fall of the PO2 only when the PO2 falls all the way to less than 60. पूरा liquidation होने के बाद the inspiratory center get excited. That's the point. Between 60 to 100 millimeters mercury of the PaO2, there is no effect on peripheral chemoreceptors. The moment it falls less than 60, then the breathing rate pattern basically changes, is what need to be remembered. Then how about PaCO2? Typically the PaCO2 rise is the one which stimulates, but earlier we said fall of PO2 and rise of CaO2, which is more important? Rise of CO2 we said, no? A small correction. Fall of O2 is much more sensitive than rise of CO2, but fall of O2 also is insensitive between 60 to 100. Only when the O2 falls below 60, then only they become stimulated. That's the point you need to remember. Small correction. Peripheral chemoreceptors will detect the rise of the PCO2, but rise of PCO2 is less important than that of the response to the fall of the PO2. Okay. Now, how about arterial pH? A fall of the pH, which is a rise of H plus ion, is very important. Now, doctor, will every time fall of PO2 fall of pH will occur only with the rise of PaCO2? No. Only if it is a respiratory acidosis, then acidosis is responsible for fall of pH, and respiratory acidosis occur when you are hypoventilating, and that hypoventilation will lead to rise of PaCO2. Can there be a fall of pH without rise of PaCO2? Metabolic acidosis typically will lead to fall of pH without any rise of PaCO2. So that is the reason, whether rise of PaCO2 is there or not, still a fall of pH is capable of stimulating the peripheral chemoreceptors, is the point that we need to fundamentally carry. So who mediates the fall of pH? There is one more tricky point about this. The fall of PO2 or a rise of PaCO2, they are perceived by both the chemoreceptors, peripheral chemoreceptors in carotid and also aortic bodies. But the fall of pH is only perceived by the chemoreceptors in the carotid bodies, but not the ones which are located in the aortic, but not the aortic bodies. That's the most important point that need to be appreciated. And of course, you know, a diabetic ketoacidosis patient who had been paraded to you, typically how does he present? Severe acidosis with hyperventilation is a typical presentation of a DKA patient in a casualty you might have seen as a house surgeon. Then what are the other receptors? We have some mechanoreceptors. The lung stretch receptors, the joint and muscle receptors, the irritant receptors, and very, very important. Lot of times in AIIMS and PGI, this question has been asked. Juxtacapillary receptors called J receptors. What is the significance of each of them? 1-2 points we need to know for the tomorrow's exam. The lung stretch receptors are mechanoreceptors. Where are they located? We have the smooth muscle in the airways. What is meant by Herring-Breuer's reflex? Whenever the lungs get distended with the air, then those receptors on the airways get stimulated, mechanoreceptors. In turn, reflexly they cause a decrease of the breathing rate whenever the lung is stretched, which is called as Herring-Breuer's reflex. And what is the effect of that Herring-Breuer's reflex? Typically this reflex, it will decrease the breathing rate by prolonging the expiratory time. It has an influence more on expiration rather than on the inspiration. It doesn't decrease inspiratory rate. It prolongs the expiratory rate. So that is how whatever that extra air causing the stretch of the lungs is being expired out. So that is a Herring-Breuer's reflex. Common MCQ asked in the exam is, who is the mediator of the Herring-Breuer's reflex? What is your answer? It is the stretch receptors which are located in the mechanoreceptors, which are stretch receptors located in the airways. So summarize, doctor, what we are learning. We have central chemoreceptors which only perceive the fall of pH. Peripheral chemoreceptors which can perceive all the three, fall of oxygen, rise of CO2 and fall of pH. Then we have the Herring-Breuer reflex because the stretch receptors in the lungs. Then in addition we also have the nociceptors and proprioceptors in the muscles and joints. Let us talk about them. So whenever we get onto the treadmill from the comfort of the early morning bed, our breathing rate starts to increase, not just because we have started doing exercise. Of course, sometimes when we go to reading room and put the Harrison, Davidson, everything on the table, our breathing rate will increase, not because we exercised a lot. It is the movement of the limbs, proprioceptors, they send a signal to the inspiratory center, which in turn will lead to the development of anticipatory rise of ventilation. Favorite MCQ of the examiner. Anticipatory rise of the ventilation whenever you start the exercise is because of what is asked many times in entrance. It is not due to any fall of PO2 or a rise of PCO2 or a fall of pH, but because of the joint receptors which are proprioceptors is what you are going to remember. For the noxious stimuli, we have the irritant receptors located in the epithelial linings of the airways. Once more, it is the vagus which carries the afferents and reaches the medulla, and it typically leads to the reflex bronchoconstriction, and it causes an increase in the breathing rate. Then what are these juxtacapillary receptors? Very, very important receptors. What are the frequently asked MCQ in the exam? In a congestive heart failure, when a person is having pulmonary edema, which are the receptors responsible for his increased breathing rate? It is the juxtacapillary receptors. Typically, they are located on the sides of the pulmonary capillaries. Any rise of the pulmonary capillary pressure will in turn lead to activation of these receptors. Rise of the pulmonary capillary pressure will lead to the seeping of the fluid into the pulmonary interstitium, and that interstitial fluid rise is a stimulant for the J receptors is what need to be remembered. That's the reason what happens if there is a left heart failure? Rise of the left ventricular pressure will lead to left atrial pressure, and who is draining into left atrium? Pulmonary vein. Who is draining into pulmonary vein? Pulmonary capillary. So pulmonary capillary pressure will rise, and that leads to interstitial edema, which stimulates the J receptors, leading to the development of the CHF associated dyspnea is what need to be remembered. So that is all the story, doctor, about regulation of respiration.